the Robert Wood Johnson Foundation Systems for Action Research Program and our recurring Research in Progress webinar series. I'm Glenn Mays, a professor at University of Colorado. I direct the National Program Office for Systems for Action. If you're new to S4A, we are a signature research program of the Robert Wood Johnson Foundation. Our mission is to study innovative ways of helping medical, social, and public health systems integrate their work better together toward the goal of improving health equity, dismantling forms of structural and systemic inequity and racism across American communities. We use this webinar series every couple of weeks to profile a research study funded through Systems for Action. We get a chance to drop into the research team, find out what they're doing, find out what they're learning, and also ask questions so that we can all learn as we do the important work of system alignment and system integration. We're really fortunate today to feature a research team based at University of Minnesota and across the state of Minnesota. And I'll turn it over to them in just a minute to take us on a tour of their research project right now. Just a couple of logistic notes first. Number one, we are recording this webinar as we do every time. At the conclusion of today's webinar, within a day or two, we'll post the recording of this webinar along with the slide set up on the Systems for Action website at systemsforaction.org. So if you have any colleagues who are not able to join us live today, they can find this recording there, and those links will also be emailed out to everyone who's registered for today's webinar. The other thing to make note of is we will have times for questions from members of the webinar and audience members of the webinar today for the end of today's hour. So if you have a question you want to ask our panelists today, use the Q&A box you should see down at the lower part of your screen. Click on that box, type in your question at any point during the webinar, and we'll get to as many of those questions as we have time for during the latter part of today's webinar. So with that, I'm going to turn it over to our research team, led by Dr. Pinar Mandic, who is a professor at the University of Minnesota in the Carlson School of Management. I'll turn it over to Dr. Mandic to introduce herself and the rest of her team.
Thank you so much, Glenn, and thank you so much to RWJF Systems for Action program for giving us the opportunity to start this very exciting research project and to learn a lot from it. So we are in our project for about a year now, and it all started with something that sounded like maybe a crazy idea, but maybe not. And we have learned a lot, talking to lots of people, doing some research, and refined our ideas. And so this is a great opportunity for us to share that with you. My name is Pinar Karacamandic. I'm a professor in the Department of Finance at the Carlson School of Management at University of Minnesota. I'm also the founding director of our Business Advancement Center for Health, BAC, that coordinates this particular study. And I'm joined here by Chelsea Jurgensen, who is going to introduce herself very quickly. She's with the Minnesota Council of Health Plans, and they're a great partner to our project and helping us get feedback and disseminate and understand the problems better. Chelsea, did you want to just say a few words?
Yeah, thanks so much, Pinar. Again, I'm Chelsea Jurgensen, and I am the Director of Government Programs and Health Equity for the Minnesota Council of Health Plans, and you'll hear from me a little bit later on with the commentary.
Thank you so much, Chelsea. And this is the rest of our research team. My co-PI is Raul Coran, who is the CEO of the Minnesota Hospital Association. Susanna Gibbons at the Carlson School of Management. She runs our funds enterprise for our MBA students. David Haynes, assistant professor at the Institute for Health Informatics, Sayenik Pei, associate professor at the School of Public Health, Richard Takor, assistant professor at the Carlson School of Management in my department, Department of Finance. And we also have Jenny Schonecker and Joe Schindler, who are with the Minnesota Hospital Association. And Kim Choi started us with this journey, as well as the Box program manager. And I would like to also acknowledge all the different partners that we've been encouraged by their word and by their passion about this topic. We have Minnesota Council of Health Plans, Chelsea's organization, Minnesota Hospital Association. We've had a lot of conversations and support from leadership in the Minnesota Department of Health and the Minnesota Department of Human Services, Piper Sandler, Prime West Health, Second Harvest Heartland, Stratus Health, Collective Action Lab, and several other organizations, nonprofits that have been sharing their wisdom with us. And the problem we're trying to solve in this project is a problem you're all familiar with: the social drivers of health, including structural racism, food insecurity, housing instability, the way we live, the way we work. We know that these factors shape the well-being of individuals, and they impact racial and health equity, and they lead to avoidable adverse health outcomes and healthcare costs. And these are big problems. Here's a map for the US for food insecurity. We are at a near average of 10.4% across the nation, which is huge for a country like the United States. And as you can see, some of the states are significantly at higher rates. And this is just the food insecurity. When you look at other social factors, the story repeats itself. And recently, we're encouraged that both the federal and state initiatives, as well as a growing number of hospital, health systems, and payers, are actually recognizing the importance of these factors. And they have programs, initiatives addressing them for their communities, for their membership, for their patients. As you can see, lots of examples on this slide. But these interventions typically occur in silos rather than being designed and implemented with a coordinated, sustainable, and scalable resourcing model. And community-based organizations, social services organizations, public health programs are actually very well positioned to address these SDH needs of their communities. But we also run into a problem that they typically are underfunded, grant funding, philanthropy-based, they lack sustainable funding. And as a result, it becomes really difficult to scale these SDH interventions and to offer continuity of access to social care. In the healthcare setting, we talk a lot about the importance of continuity of healthcare, but in the social care space as well, continuity of that social care as people move in and out of their plans or become uninsured, this is critically important. So ultimately, the problem we're addressing is that the lack of efficient and sustainable funding for social and community-based organization services that impact health and health equity. There is a critical need for innovative financial systems to enable that efficient and sustainable funding for projects that target SDH and improve the allocation of resources to address these important dimensions of health equity. So our project goal, the way we started, is that we wanted to approach it coming from primarily from a business school. What can we do as the business school with the business school toolkits that we have? Can we think of addressing that sustainable financing issue by designing a novel financial instrument, which we are calling a social drivers of health bond, or an SDH bond. And the idea is that can we pool resources from multiple competing health plans and create some stable long-term financing for interventions that address SDH? And of course, that can happen many different ways, and we have a particular approach that I'm going to outline. By the way, all of the work that I'm presenting basically represents the learnings we've had over a year, which is also published in Health Affairs, March 6 issue, which is an open access, free access article that matches the title of this talk. So you can refer to that and read about our work in more detail. The key features of our idea is we wanted to focus on the Medicaid population. The second key feature is that we want to allow multiple health plans participating in the Minnesota's Medicaid managed care program to collectively issue and administer a bond. So the idea that we have is not about asking the MCOs, Medicaid MCOs, to upfront certain amounts of funds to fund these programs, but the way we're approaching it is actually, can we bring in funds from the investors, individual investors, mutual funds through the capital markets to actually curate that pool of funds, but that will be administered jointly by the MCOs. And then the funds will then be financing the community-based interventions targeting some of these social issues that we described. And the idea is overall, as we provide these community-based organizations social services, the fund that they deserve in a continuous and a sustainable way, people's health will improve, which will lead to cost savings, which will then be used to pay back the investors. So that's basically the bottom line, the core of our idea that we're proposing. And there is an important business case for SDH interventions, and we chose to focus on Medicaid for several reasons here. As we know, this is a population where we have the very complex, very extreme SDH complications that can interfere with the patient's ability to adhere to care. And that's also the population where impacting and addressing these needs and improving racial and health equity is extremely elevated. And when we look at the size of this market, we have 84 million individuals in the US covered by Medicaid, accounting for about 17% of the healthcare spending. And then when we take that perspective of a Medicaid MCO, managed care organization, receiving capitated payments per enrollee, and they're at risk for medical spending, addressing these SDH needs of their enrollees actually has a really robust business case. So, for example, addressing the food insecurity of a diabetic enrollee will improve access to healthy foods and nutrition, and will then result in reduced diabetes complications, avoidable hospitalizations, and reduce healthcare utilization. And in addition, what we also see in the state Medicaid programs is that they have actionable policy levers and flexibility to address some of these needs of their communities. For example, based on some data from 2019, about 40 states are working to address SDH needs with a wide range of activities through their contracts, through their waivers. And for example, again, among those states with MCOs, 32 of them had an MCO contract requirement to have at least one SDH strategy. 28 of them required referring enrollees to social services. 25 required screening individuals for social services. 22 required MCOs to partner with CBOs, the community-based organizations, or social services providers. So there's a lot of actionable policy that we can perhaps impact. Of course, our project team is in Minnesota, so I want to give you a little bit more context of Minnesota and Medicaid. We Minnesotans are very proud in terms of, overall health of our state, but we also have a Minnesota paradox that we acknowledge, and where we know that there are significant racial disparities, income disparities in our state. For example, we're the second biggest income inequality gap between Black and white people in the entire nation. We're one of the widest home ownership gaps, more than double food insecurity reported by Black and Latino Minnesotans relative to white Minnesotans. Again, Minnesota Medicaid, huge program, an extremely important source of access for Black, American, Alaska Native, Hispanic, Latino Minnesotans. As you can see some of the statistics here, 41.5% of Black Minnesotans receive their insurance through Medicaid, 39% of American and Alaska Natives, 29.5% of Hispanic and Latino Minnesotans. And similar to other state Medicaid programs, Minnesota Medicaid has key levers through eligibility and enrollment, through access, quality, other early opportunities, both in prenatal, maternal, early childhood programs. The list is ongoing. All right. So let me move on to describe the way we are framing the problem that we're trying to solve as the wrong pocket problem, right? So from the perspective of an MCO, as I mentioned, receiving these capitated payments at risk for medical spending, addressing some of these needs are critical, it has a business case. However, we also know that SDH interventions result in health improvements over a long period of time. The diabetic patient that we help with nutritious food over a long time period, some of that benefit is realized right now, but a lot of it is long run, doing it consistently, systematically for long periods of time so that we can avoid those diabetes complications down the road. In a few years, we can avoid that heart attack, heart disease, or cardiovascular hospitalization. So, and there are issues with the way contracts are set up, right? So, while these returns of SDH investments to MCOs are realized in the long run as these cost savings, these MCOs are not guaranteed to realize these future returns for two main reasons, and probably more, but the two big ones that we identify are there's a volatility in Medicaid enrollment because Medicaid by its nature has a high churn rate with lots of people coming in and out of Medicaid with month-to-month changes, entry and exit, and then plan switching. And then also the way a lot of states do their Medicaid contracts is through a competitive bidding process. So MCOs that are serving this community today may lose their contracts next year and thus not really realizing the benefits of their SDH investments today. And this brings us to a very well-known problem in economics as an externality or a free rider problem. But the end result, the theoretical and the empirical end result is that we end up with inefficiently low SDH investments. So I'm going to give you a little bit of a run to kind of give you an example of this underinvestment. Again, very, very super simplified example, but consider two MCOs, MCO A and B, and let's say that they have 10,000 members each, right? And they serve the one community. Let's now look at a meal program, tailored meal program. Let's say it costs $2,400 per member in year one that these MCOs are interested in investing in. If they invest on all 10K members who are eligible and who they know will benefit from this program, we know that they'll each incur a cost of $24 million. And let's say that the meal program, there's a 75% return on investment, and that's sort of like the ballpark from the literature, maybe even on the little lower side, if you look at some of the averages, is that there will be a cost savings of $4,200 per member in year two. So each MCO is going to expect about $42 million of return, cost savings, with expected net gain 42 minus 24, 18 million each. So that's big. There's a value of $36 million of net gain because, and we're making people healthy, right? So that's where we are starting. And so that's what we want to achieve. But then consider that we have actually one of the MCOs, let's call it MCO A, has some chance in this case, just to put some numbers out there, 30% chance that it's going to lose its contract in year two. And let's say it loses a county or two, and then it will lose 50% of their members to MCO B. Okay, again, very simplified. All the membership stays with A and B at this point. But when A loses its members in year two, the expected number of A's members in year two is 8,500 rather than the 10,000. So that additional 1,500 goes to MCOB. When you look at the cost savings from 8,500 people in year two, the expected cost savings in year two is $35.7 million. Okay, so basically, when we think about MCOA, if they invest in all members in year one, which is what we want when we think of a socially optimal way of looking at it, they are going to invest and they're going to incur the cost of $24 million, but in year two, their expected savings is going to be $35.7 million, just based on that 8,500 members. So there's an expected net gain of $11.7 million, okay? Whereas the net gain for MCOB is higher because A invested in some of those members, which moved to B in year 2. All right. So can MCOA do better? There's a net gain, that's good, but MCOA can actually do better. They can invest for meals for 8,500 people instead, because in expectation, that's the savings they're expecting to recoup in year 2. So if we do the 8,500 members, if you look at that third panel, you will see that their expected cost savings is $35.7 million. So their expected net gain is actually $15.3 million. So instead of gaining 11.7 million, they're expecting to gain $15.3 million. But then look at the total gain to A and B, right? The total gain is 33 million as opposed to $36 million, because MCOA chose to invest in 8,500 people instead of 10,000 people because of this churn or departure from A to the other MCO. So what our proposed solution basically says is that we are going to let's have A and B join forces together and issue a bond, just like a savings bond, under a legal entity that we're calling Special Purpose Vehicle, SPV. And we are going to have individual investors, you and I, or mutual funds that will actually purchase this bond. And we are going to call this a social drivers of health bond. The social aspect of it comes from the fact that the SPV ensures that the proceeds, the funds that are raised, will go to SDH interventions for the MCO enrollees. As I mentioned, overall, we expect the health will improve, some cost savings will be realized, and now when it's time to pay back, MCOs will pay back based on the estimated cost savings, based on the estimated patient enrollment on the NCOs or SDH interventions. So how does that solve that wrong pocket problem? As you can see, the fourth panel here, going on that story with A and B, what we are doing is this bond will be issued, the SDH bond by A and B in year 1, and let's say that we are able to raise the funds so we can actually go to that socially optimal level of we invest for all 20K members in year 1. 10K from A and 10K from B. So we do incur the investment costs of $48 million. We are going to have $35.7 million cost savings by A because of that departure to B, right? And a higher amount of cost savings by B, 48.3 million. But then when the time comes to pay back the bond, let's say in year 2 after the cost savings are realized, we will have an accounting process in this SPV will set up so that essentially 20.4 million will be paid back by A, 27.6 million will be paid back by B. So essentially A is paying less than B, reflecting that some of A's investments in year A or that went actually to benefit MCO B's membership. So that's basically what the bond is trying to correct, going from that privately optimal to the socially optimal level of investment. And there are a lot of additional benefits of this SDH bond that we see. It harnesses the power of the broader capital markets and brings a great influx of funds and engaging socially minded individuals. And then we are creating this one pocket for actually to allow for the social care piece of it, so that we are allowing for the continuity of social care, even if enrollees switch plans from A to B. The idea we have is that these proceeds from the bond will be used to, again, invest in all 20K members so that we have, if people from A to B moves, their social care does continue. It's about a pooling mechanism, creating a pooling mechanism as well across multiple SDH projects, across multiple MCOs, and that's just a basic argument for some financial risk reduction through that diversification as well. Also, the way we're envisioning the payment back is not by tracking actual cost savings that can come up, create a lot of cherry picking type of issues and in the health plan side. What we are thinking is based on estimated savings. So you as the example that I showed, what are the estimated cost savings for A, what are the estimated cost savings of B, and using those estimated cost savings rather than actual medical cost tracking. So we are actually reducing incentives for cherry picking and release. The one other very interesting thing is, like I gave the example to you as two MCOs joining this SPV, nothing prevents a state entity or a federal entity being part of this bond and creating a public-private partnership. State Medicaid agencies can be part of the SPV and partner with the MCOs, and there are very good reasons for this. What we have learned through this year, talking with lots of people and doing some research on our own as well, is that there are important challenges and key considerations, and they just keep adding to the list, which is the fun thing about research. Is one important thing is this determining the structure of the bond, right? The maturity of the bond, is it 2 years? Is it 4 years? Is it 5 years? The coupon rate, how many MCOs do we need to have to make for this to make sense? What are the minimum number of enrollees so that we can actually make some statistical kind of judgments around this, whether the bond is backed by state and federal entities, because that's another thing when we're putting the MCOs at risk in this model. Backing may actually bring in more MCOs to the pool. And then the possibility of risk sharing with investors. The way I framed it so far is our baseline thing says, okay, the MCOs issue the bond, MCOs are at risk by for paying the bond in the future. They're not upfronting anything, so it eases the burden, but the expectation is that they will receive some cost savings which they can use to pay back the bond. There are many different ways that there are granularities around it and a whole spectrum where risk sharing could be incorporated through the creation of different investment tranches. So for example, it could be based on some key outcomes of importance and that the investors, importance to investors, so that, for example, if those key outcomes are achieved, managed care organizations may be required to pay back smaller returns. This brings it from the social drivers of health bond to more social impact bond, where the risk shifts to the investors. So those are all things one can consider. Understanding the impact of different types of STH investments on the structure of the bond is super important as well. And so one of the ways we think the bond is better suited is for the types of STH interventions that are typically more capital intensive, perhaps, yielding benefit over a long run. And this housing, transportation, those are great examples. But it could be possible, it would be possible to blend in some of the STH interventions that are more annual outlay specific, and that may require a rethinking around how the bond is done, or we may be thinking about multiple SPVs, some of them for longer time period with the annual maturity, some of them shorter, again issuing bonds over successive years to manage that blend of long outlays, capital intensive versus the annual outlays type of projects. But in all of these cases, all terms have to be agreed up front. And again, in all of those cases that I described, the expected return on the STH interventions and for the type of interventions that the bond will want to fund will determine the optimal blend. Coordination with state Medicaid agencies is extremely important because we have the legacy structure of the Medicaid financing. So we need whatever we create to actually coexist with these legacy structures. Questions around, can we incorporate STH bonds into the regular MCO procurement cycle? For example, during the contracting process, would states look favorably on MCOs that actually participate in an STH bond? Would policymakers allow for higher contract amounts to reflect organizations' commitment to STH activities? So again, we're seeing a lot of signs of this in the existing contracting cycles, but it's also, it would be important to kind of think of it in the context of the bond as well. There are a lot of other state policies like the medical loss ratio, premium rate setting policies, and other types of state initiatives to reduce health disparities. So state by state basis or community by community basis, thinking about how such policies interplay with this bond idea is one will have to be considered for implementation. We sometimes get this question, well, there are a lot of other social benefits and spillovers of these interventions, right? Reduced levels of homelessness, less strain on mental health and criminal justice resources, even environmental resources. So like, how do we, a lot of other people are benefiting from it. And again, our team's thinking around this is that nothing prevents those organizations to be part of this bond and to be part of the issuers of the SPV. Although we see the MCOs as a clean case because they are receiving the direct cost savings. There are other ways, as I mentioned, in public-private partnership type of thing that other parties can be part of it. Monitoring the use of funds and measuring returns. This is very challenging because SDH interventions typically don't have procedure codes. Doesn't mean they will never have procedure codes. That's something we need to be thinking about. But it will be important to sort of have the data infrastructures and tracking and participation and data to assess some of these cost savings, and then later on possibly assigning responsibility of paying back the bond. Again, in the first few years of implementations, to clarify, this is not an implementation project, but we are having that eye forward and looking forward to kind of thinking about this. But you know, we're thinking about estimated savings, but then over time, if this is implemented, we will actually get data on cost savings, and they could be reflected into how we pay back the bond. Identifying appropriate data on return on investment is a huge gap in the literature, although more and more evidence is being published that we see. There are only a few studies that report on ROI of specific SDH interventions, so that's one of the challenges. And then sometimes you can see ROI in terms of cost savings, but cost estimates are not always available or reported. Some of the things that we see in the literature may not be generalizable to the Medicaid population. So that's something we need to think about as we read these studies. And then measurement usually focuses on changes on healthcare use. Like, so we would read studies like, okay, there is a 20% reduction in hospitalizations, or there is a, 30% reduction in ER visits. But then we need to then take that data and somehow in an apples to apples way, which I'm going to give you a little bit of our work in this in a bit, convert that to cost savings estimates so that we can calculate the ROI in a apples to apples ways. Yeah, and then sometimes these inputs for modeling may have to come from key stakeholders such as MCOs or community-based organizations, and thinking of the bond and in what community it applies. In one community it may look a little different than in another community. A part of the project that we haven't gotten yet, that we would basically, it's like a next big project that we would want to pursue, is how do we allocate the funds? Let's say that we've created a system where we can raise funds. What are the best ways of optimal allocations of selecting interventions? Again, we have some preliminary ideas around this. So for example, one idea we have is that there could be an RFP of announcements and review panels, much like we see in like basic NIH panels and things like that. But there are challenges because community-based organizations may not always have the financial sophistication to estimate the full cost of the interventions nor the full benefits. So it may be necessary to rely on trusted community partners to help the community-based organizations to respond to requests for proposals. Engaging individual investors in the process. Again, there you have to do a very balanced way of looking at it, because yes, if you can engage individual investors so they have more of a say of where their money is spent on, we may increase funds, but overall we're funding a platform of STH intervention. So like trying to blend in those platform incentives and objectives. So we have a well-represented set of STH interventions that are funded is really important. And sometimes the communities have these community health needs assessments. So that's where area we appreciate opportunity as, leveraging them to understand the needs and to find the most relevant STH interventions. So what our approach has been so far is, as I mentioned, I've described you our findings. They are relying on a lot of key informant interviews and understanding, looking at different types of models. We've done a lot of work on the literature review and looking at the best evidence and the data out there for us to estimate the ROI of STH interventions, which I'm going to present to you. We're pretty much completed that task. And then we've started simulation exercises to simulate and assess the performance of the bond. We're first documenting the simple example I showed you. We're now kind of documenting it with simulation methods to see the value that a bond like this can create. In terms of solving that externality or the free rider problem. And then now we're laying out the bone structure on that simulation to start investing in certain types of projects. And then we will be moving on to some scenario analyses. So here is some information that I want to share from our key informant interviews with local health systems in Minnesota. And these were led by our team partner, Minnesota Hospital Association, and in a careful way to represent both rural and urban health systems and other organizations. One of the big messages that we heard is that the barriers to healthcare as well as STH differ by rural and urban areas, and that's probably not a surprise. So for example, transportation, when you think about it, in an urban setting, it actually transportation is a bigger challenge in terms of it's more than just the ability for the patient to have transportation to and from medical appointments. The lack of transportation limits the ability to participate in the community CBOs, community-based organizations. And a lot of health systems and organizations, they rely on the CBOs to address the patient needs. They're not equipped by themselves to address these social needs. And it's very difficult for them to administer some internal programs, especially for small health organizations, and that the CBOs have trusted relationships with communities. And again, when you think about urban versus rural, the urban areas have access to a lot more CBOs than rural areas. So that's a challenge. The second key takeaway from these informant interviews is most health plans and health systems and hospitals, they identify patient needs in STH through screening surveys that the provider asks these. And an important indicator for STH needs is uninsurance. And that's something that our state is working really hard to address. Typically, most frequent or immediate need is food, while housing remains a very important program that the hospitals are struggling to tackle for their patients. And screening through primary care providers, these health systems reported, has been a really successful and a consistent way to identify the needs in the community. Third challenge is EHR integration. Some EHRs, such as Epic, they have STH integration or some ability to record patient needs and referrals. But some of the interviewers reported that these are sometimes still in provider nodes. So being able to consistently enforce the EHR integration to track patient progress and track ROI is important. Again, the funding sources, these health systems validated the problem that we think is also really important. The funding sources where their programs are often hodgepodge, blend of private grant government programs, but also innovative hospital CBO partnerships have been emerging, as well as some reliance on models that reimburse on outcomes. So, for example, I believe that there is one hospital in this group that purchases food directly from local resources, and then the farmers in the summer, and then partners with an urban area organization in the winter. So, again, another rural health system in this case is applying like a hub model where it has a charity foundation and community health team that works with this, but the community health team is reimbursed only when they complete a full pathway. And so there are interesting models emerging. Okay, so then I mentioned the ROI is really important, and again, so we've taken some sort of, as best as we can, a systematic approach looking at the Siren network, PubMed, as well as some review articles like the National Academies of Sciences, Engineering, Medicine had this really cool gathering where we learned a lot. Review of evidence for health-related social needs interventions, something from the Commonwealth Foundation. But so the way we looked at it is because we want to identify different types of SDH interventions that are, and figure out their ROI, right? So we focused for now on food and housing as SDH factors, as some of the bigger factors that we heard in these informant interviews that I mentioned. And then we limited our search to studies with some cost and utilization data, because again, in our model, the idea is health will improve, but that will lead to some cost savings or utilization savings, which then leads to cost savings. And that's what we're trying to measure. So we had kind of like going down the steps, 33 articles on food and 77 articles on housing. But then we basically further limited those to articles that actually looked at studies that looked at a specific food or housing intervention. So, for example, we excluded the types of studies that were only focused on identifying some SDH factors through surveys and claims and EHR analysis without a particular food or housing interventions, or that we did not include studies that provided like a program that is just a little bit more like provides a check-in and support, referral and navigation, which are really, really important, don't get me wrong. But while those studies, they allow for estimating sort of this impact of comprehensive set of SDH factors, they are specific, they tend to be in the literature specific to a delivery method through something that is administered through care managers, community health workers, or the community health center, or that they're specific to a program type like a transitional care program or behavioral health wraparound, and they don't necessarily allow for carving some of these specific impact of targeted interventions. So we are down to 23 articles on food and 30 on housing, and then we report to those that actually report on outcomes on hospitalizations and ER visits, which limit the set a little bit more. And then based on that, we did something really cool. We basically looked at the study populations of each of these, and then we assessed some intervention costs and savings and estimated them by actually mapping all of these studies to the medical expenditure panel survey of 2019, just the year before COVID, and trying to understand. So let me show you a little bit more, but so basically, the studies also differ in the way that they are administering their study design. So very few of these studies have more what we call maybe the gold standard randomized control trial type of study designs, but some of them have match comparisons groups, and some of them have pre-post or the differences in difference type observation study groups. So a little bit more data on our food interventions. So when you look at it, it's important to kind of group them as different types of populations. So some are looking at dual eligible, some are looking at recently discharged patients, some are looking for those at risk for admissions, or those at or below 200 FPL. The type of interventions vary: medically tailored meals, Meals on Wheels, SNAP. Design is, again, mostly match control studies. Outcomes are studies report on changes in hospital days, hospitalizations, costs, readmissions. Cost of the intervention is typically not reported. So when it is not reported, we read the paper and we then infer the estimate, like from other studies that have done similar interventions, the cost of what an intervention may be. And this is the summary of our ROI. It ranges from 34% to 266%. Overall average is about 126% ROI when we look at food interventions, but of course the distribution. So this is like just a sample of, I guess, like several of them. So we look at the population, hospitalized chronically ill population. What we then do is that, for example, the study says there's a benefit. It reduces inpatient hospitalization risk, 1 year inpatient hospitalization risk by 47%. So what we then do is we look at the maps, we look at the hospitalized chronically ill patients, we identify these conditions that the study report in MAPS population, and we look at the hospitalization costs of that particular study population, and then we apply the 47%. So that's sort of how we do our ROI estimates. And again, dual eligibles, again, we look at the dual eligibles in MEPS, and we look at their inpatient hospitalizations overall. Again, the first study is like those people who are already hospitalized, their high hospitalization costs. If you look at dual eligibles overall, they don't have as much on average hospitalization costs as the already hospitalized people. So we applied a 52% reduction to the hospitalization estimates for the dual eligible. So that's sort of the approach that we're doing. Housing interventions, again, the population varies between homeless adults with chronic illness, seniors, Medicaid, dual eligible, chronically homeless. The types of hospital interventions range from, interim housing, emergency housing, some stable housing after recovery, and so on. Looking at different kinds of like ROI, again, sometimes these housing initiatives are supplemented by some case management, and that's where we see higher ROI. And then if you look at an over average ROI across all housing initiatives is about 74%. So what we're doing, we look at these initiatives and we're trying to kind of map them to those that have important financial return, those that are really impacting health equity and racial justice. And then we kind of map them up, and the next steps that we're doing with our simulations is basically building these types of projects. And now that we have a good set of projects that we can work with, we will select some of them, both high returns, racial justice, health equity, as well as financial ROI, versus then we can blend in some of the projects that may not have high financial ROI, but are really impactful for health equity, and then kind of just see and estimate how this bond performs in terms of the returns and the savings, and blend in some of these like private and public partnership scenarios where a public entity like the state Medicaid agency or the State Department of Health may just say, we want to be able to be part of the SPV because we want some of these projects that are impactful for health equity and racial justice. Maybe they don't have high financial return, but we don't care. It's important for us to have it. And this is the sort of the subsidy that we're putting in to make the financial aspects of the bond still attractive to investors. Again, moving on to building a lot of stakeholder engagement, different maturity structures, and so on and so forth. And next steps, as I mentioned, we're starting to build numerical exercises with the bond returns, finishing up our ROI estimates, and really thinking about stakeholder engagements. And so we're having really interesting engagements with housing initiatives, housing programs at the moment, to learn how something like this could benefit them. relatively new and emerging area of finance. It's like we may have heard these kinds of models in green finance, climate finance, but this is the first time we think of using some of those sustainable finance or ESG strategies into Medicaid and into supporting social drivers of health. And this is our project team and mentioned before, and our partners. And thank you so much. The one little thing that I do want to mention, our center, Business Advancement Center for Health, has an upcoming conference next week, Convene conference, in person, but also virtual. The theme of it will really benefit this audience: data, technology, and connectedness to health. We have sessions that talk about data connecting payers and health systems with their communities, health equity with a global view, advocacy and policy for value and equity, as well as how do we do equitable, affordable care and measurement as a key engine. And if I may ask Becky, our team member, to just put in the link in the chat. So if we would welcome all of you. It's free registration for virtual anyways. We welcome you. And then with that, I will stop sharing and move it to Chelsea for her commentary. Thank you.
Yeah, thank you, Pinar, for presenting an update on the work. These are really interesting ideas and they're very relevant, so I'm excited to see how this project continues to develop. Hi, everyone. Again, I'm Chelsea Jurgensen, and I'm the Director of Government Programs and Health Equity at the Minnesota Council of Health Plans. And we are the trade association for Minnesota's nonprofit insurers. Our members include Health Partners, UCare, Medica, Hennepin Health, Sanford Health, and Blue Cross Blue Shield of Minnesota. And importantly for this conversation, we represent 5 of the 9 managed care organizations in Minnesota, with around 84% of all Medicaid managed care enrollees in Minnesota served by one of our plans. So thank you so much again for inviting me to provide some commentary on the project so far. I do have a couple of reactions to offer on Pinar's research, and I'd also like to speak to a few things that we're seeing in Minnesota specifically. So first, I think we can all agree that this research is very timely. In the early days of the Medicaid program, we didn't necessarily have a term for the impact of these non-medical issues in a person's life, but today we know that these social drivers of health actually account for around 80% of a person's health and well-being, with only 20% being determined by their interactions with the medical system. Perversely, though, the overwhelming majority of funds go to financing the medical system, with very low sustained funding and long-term investment in the day-to-day needs of someone, like housing and transportation, childcare, food security, racial inequity, and other things. So that really is the heart of the wrong pocket problem, and Pinar's research does a lovely job of articulating that. I also, of course, wanted to speak to the importance of managed care in Minnesota, but also in this research specifically. As managed care organizations, we've actually been doing community work for a long time in ways that I think would be surprising to a lot of people. Particularly in Minnesota, where managed care has been in place since the 1980s, managed care organizations have been tasked with ensuring the well-being of our members, but we also have to keep costs down and provide high-quality care. So naturally, we've been working on addressing these upstream barriers to health for a long time in order to achieve all of those things. And again, given our MCOs are local nonprofit health plans, we not only understand the circumstances of our members in a way that other entities might not, but we have both a mission and a mandate to invest back into these communities because of our nonprofit status, but also because we live and work here too. So I think it's because of this longstanding tradition of having these local nonprofit health plans and managed care that our existing network of MCOs are already highly collaborative and highly engaged in this work. And not just to say with other health plans, but also with the state Medicaid agency, local public health, provider organizations, and community organizations as well. So we have a really strong foundation to support innovative approaches that ultimately benefit all of our collective members. And we also have the flexibility to address these issues in a way that oftentimes the state can't. So it'll be exciting to see whether Pinar's research can map out a new way of doing this collaborative work more efficiently and also to a greater benefit. Finally, I think one of the most interesting aspects of Pinar's project is that it develops a way to minimize the impact of churn when funding non-medical health needs. Churn, of course, has always been an issue in Medicaid, and really we see that across all means-tested programs. But I really want to call out that we're having this conversation today in one of the most unprecedented times in Medicaid since the implementation of the Affordable Care Act. For those of you who aren't familiar, the last 3 years, the federal government has paid states extra money to keep all public program enrollees continuously covered during the public health emergency in order to ensure that they had access to care and treatment for COVID-19. So states couldn't terminate coverage for anyone except under a very, very narrow set of circumstances, meaning we now have record high enrollment in Medicaid across the country. In Minnesota, we've seen a 30% increase in enrollment from now to before the pandemic started. However, now that most of the provisions of these continuous coverage mandates have sunset as of April 1st of this year, we're entering a new phase of Medicaid policy, and you'll often hear this referred to as the unwinding period or the redetermination period. But what it means is that every single person enrolled on Medicaid or a basic health plan will now need to have their eligibility redetermined over the next 14 months or less. And we know that this is going to lead to unprecedented amounts of churn and volatility. So importantly for this project, I expect we're going to learn a lot about these populations who are most at risk for churn, and we'll understand their barriers and their needs in a new way. And hopefully that will allow us to think about how to remake our systems so that they really work with people rather than against them on these programs. And I think the unwinding period should be seen as a catalyst for long-term change, and it presents us with the opportunity to think creatively about building person-centered supports and equity into Medicaid in a way that we really haven't before. So it does really seem like now is the right time in particular to also reimagine how we think about and prioritize funding for social drivers for our most impacted communities. And my hope is that PNAR's research can really build in the learnings from this unwinding period and help present options for aligning the financial side of the work with the very real and human equity needs of communities. So I want to make sure we leave time for questions. I'll end there, but thank you again so much to everyone involved in the project, and I look forward to the conversation.
Fantastic. Well, thank you again to Pinar and to Chelsea for really exciting work overview of this research, and Chelsea's commentary, I think, right on target in thinking about how this can inform future policy developments in the current environment. We've got just a minute or two for questions. I'm gonna do the difficult decision of picking one of these great questions to see if we can elaborate on it a bit. A couple of questions touched on the issue of, you know, if these SDOH interventions are high value, why aren't governments just using tax revenues to invest in them directly? What's the value added of the special bond mechanism? And maybe related to that, how might this mechanism play out in different political contexts? One questioner mentioned politically conservative states that may be resistant to direct government investment in some of these kinds of activities. Any comments on those issues?
Yeah, and by the way, I'm happy we're gonna, as a team, respond to all the questions that are sent our way. So we'll do that. But I think my first reaction to that, Glenn, is, I mean, that's a great question. But then again, one thing that is actually interesting about the bond is we're bringing socially minded individual investors and the capital markets as being part of the solution. And in fact, in an interesting way, it may be more amenable to in the states where you have more conservative governments, where because we're bringing and blending in the market as a solution.
Fantastic. I think that's really right on target about an important aspect of the innovation in this work. Well, we are at the top of the hour. I want to thank everybody again for joining us. Thank you again to Pinar and to Chelsea, and really to your entire collaborative research team on this work. This is definitely work in progress, so we're going to want to invite you back as you begin to have more findings and lessons learned from this work. Thanks to everybody for joining our webinar. Definitely continue to track our upcoming webinars. And as we mentioned, if you asked a question we didn't get to today, we'll be following up with the research team offline to get you those answers and to steer you to additional resources about this great work. Thanks so much for joining us, and enjoy the rest of your day, everybody.